We are live.
So welcome everyone to this module 2 of the certification course on management of myopia. And this module 2 is myopia documentation. I'm thankful to Dr. Jitender Jethani, who is the program director for this certified course from the All India Ophthalmological Society Scientific Committee. And I'm sure we are going to have great learning. There are altogether 11 modules here, and after each module, there are going to be questions which you would need to answer, and you can also answer these questions later on if you want to take the questions later. So, with this, I think I would request Dr. Jitender Jethani to start this module number 2 on myopia documentation. Over to you, Jitender.
Thank you so much, ma'am. A very good afternoon to everybody. This module 2 is basically on the myopia documentation. The module basically would take care of all the investigations and diagnostics that we should be doing to document that a particular patient of myopia is indeed progressing and needs some sort of intervention, and we can easily find out which patient or which child needs treatment and which one has to be left over. So we have a very comprehensive experts with us. Dr. Jyoti Matalia, she's joining from NN, and Dr. Reena Gupta, she's joining from PGI Rohtak, and Dr. Kalpit Shah, he will be joining. So basically, I'm really thankful to the experts, for taking out time on a working day, in an afternoon. Almost 1.5 hours they will be with us together, and we have two eminent speakers also. Dr. Shruti, she has joined from Chennai, and Dr. Deepthi Joshi from Bangalore. So we will start. I will hand over to Dr. Ankita and Dr. Anupama. They will be the moderators for this particular module. So yeah, Ankita is there. Dr. Ankita, please, you can start the module.
Good afternoon, everyone. First of all, I would like to thank the AIOS committee and Dr. Jethani sir for giving me this opportunity to moderate the module 2 of the certification course on management of myopia, which is focused on myopia documentation. I'd also like to appreciate Dr. Namrata ma'am and Dr. Jethani sir for coming up with such a fantastic idea of the certification course. Module 1 was a huge success with engaging and informative talk, and we are really looking forward to module 2 today. I also invite our expert panelist, as sir mentioned, Dr. Jyoti Matalia from NN Eye Hospital, Dr. Reena Gupta, and Dr. Kalpit Shah. Thank you for being with us today. Most of the conferences talk a lot about myopia control measures and treatment options, but one very important aspect that often doesn't get enough attention is documentation of myopia management. And this is not just about measuring axial length. It includes several other important parameters that helps us to track progression and plan long-term treatment. So this myopia module 2 is all about myopia documentation. It gives me immense pleasure to introduce my colleague and friend, Dr. Shruti Nishant. She is the Chief Pediatric Ophthalmologist at MN Eye Hospital, Chennai. She's also a clinician researcher and is currently in the final year of her PhD in myopia. So honestly, there couldn't be a better person to speak on myopia classification and progression. Over to you, Dr. Shruti.
Yeah, thank you, Dr. Ankita. At the outset, I wish to thank you for the kind introduction, and also Dr. Namrata ma'am and for Dr. Jitendra Chetani for putting up such a wonderful module for myopia. And I think it's much need of the hour. Dr. Jitani was telling me that indeed it was on feedback. This is one of the modules that was much in demand. So today I'm going to be talking something a little different. I suppose we are going to start with before going on to assessing and going on to monitoring or how a myope should be or how it should be handled. I think we need to understand what is myopia and how do we do the definitions and classifications of them. Please stay with me because sometimes, it may get a little too intense, but unless we know this, then we cannot progress on to, documenting and assessing it. So, the current version of the World Health Organization, that is the ICD-10 and now the ICD-11, define myopia as a refractive error in which rays of light entering the eye parallel to the optic axis are brought to focus in front of the retina when the accommodative status of the eye is relaxed. Now, this is a definition that we are all aware of, and this is how we normally write in our exams as well. Now, there is a body called the International Myopia Institute, which is now convened to kind of take up myopia in a much more intensive way. And they kind of had a slight proposal to WHO for a slight change in the definition, in which they address the issue of what the myopia is. So if you look at this, this is probably a definition, the WHO definition is probably one that does not talk about whether it's axial or what kind of myopia it is, whereas the one that in IMI clearly explains that the resulting axial, the myopia is axial in nature, that is the eyeball being too long from front to back, but it can also be caused by an overly curved cornea and or lens with an increased optical power. So this further definition of myopia is very important, because myopia as such can also be caused or an iatrogenic change that can be brought about because of other factors as well. So we need to define myopia in a proper way. Now let's move on to qualitative definitions. Now in the earlier days, there were so many types of definitions that were given for myopia. It was frankly quite confusing. You had benign, axial, physiological, refractive, school myopia, simple myopia, based on the age of onset, the progression pattern, the amount of myopia, and the structural complications. Now, all of this, because the myopia is a multifactorial disease, it's very tough to put it into one bucket and call it this is what it is. So we need to have multiple different kind of definitions for them. And notwithstanding the transient forms of myopia that are usually pseudomyopia because of instrument measurement errors, because of night myopia, or even accommodative spasms. Now, having said that, the three main classification of myopia that we would probably look at is axial, refractive, and secondary. And this is what IMI proposed, and this is what we are currently looking at. Axial myopia is the myopia that we would like to intervene. That is a myopic refractive trait that is attributed to axial elongation. Now, refractive myopia is another type of myopia where it can be because of different structures contributing to the myopia, such as positional or lenticular kind of myopia. Then the secondary myopia is the one where the refractive state is changed or altered due to a clinical syndrome, such as ROP or syndromic myopia, or due to drugs, or due to any transient corneal disease, even keratoconus. And these kind of diseases are the ones that are leading to the myopic change in the eye. Now, when we look at an so when we look at the kind of myopia that we don't want to be treating, it is this. This was a child who had a myopia of -1, but when we looked at her axial length, you can see that clearly this this axial measurement is 22.7 in the right eye and 22.79 in the left eye. Again, that's something within the emmetropic age range for a child of, say, 10 years old. So what was the problem here? The problem was that this was a steep cornea leading to a myopic refractive error. And this is what will come under a refractive myopia. So this is not an axial myopia. This is a refractive myopia. And this type of myopia, we do not want to intervene or manage with myopia control strategies. Rather, we would like to manage them with prevention of rubbing of eyes and making sure they don't have allergies or so on. Then, of course, the second type of thing which was talking about, the secondary myopia, are the ones that are the ROPs who are lasered, or the syndromic myopes that we see in most of these kind of syndromes, the Bardet-Biedl, the Noonan, albinism, nephrotic syndrome. These kind of myopes also do not require active myopia control strategy. So again, clearly curvatural positional myopia, retinopathy of prematurity, syndromic myopia, these are myopes that we really don't want to intervene with myopia control strategies. Now let's look at some quantitative thresholds. Now we have kind of defined them qualitatively. When it comes to quantitative, now this is again an IMI paper that I would like to quote. They did a retrospective analysis of 138 epidemiological studies of how they've defined myopia, and you see most of them kind of fell between less than 0.5 or less than or equal to 0.5. So myopia is probably a condition where the spherical equivalent objective refractive error is less than or equal to 0.5 diopters in either eye. And this is what we would probably define as myopia from a quantitative standpoint. How about high myopia? Again, this paper looked at 59 epidemiological studies, and they saw that most of them kind of fell between this less than or equal to -6. So high myopia is a condition where the spherical equivalent refractive error is less than or equal to -6 diopters, when the ocular accommodation is relaxed. Now, there is a little bit of a controversy here because the WHO defines high myopia or less than or equal to 5 diopters, whereas the International Myopia Institute defines high myopia as less than or equal to 6 diopters. Now, there is a conceptual difference between these two, and I'll tell you why. When you look at the WHO definition, the whole goal of WHO was to kind of define how much of uncorrected visual acuity, how much of avoidable blindness there is in the society. And when they looked at that, a -5 diopters of uncorrected myopia gives about a visual acuity of 6/172, a level that meets the threshold for blindness. So in order to define blindness, they took this refractive error. So this approach emphasizes the impact of uncorrected refractive error in a population. So it basically leads to visual disability in the community. However, when we're looking to myopia control strategies, we want to look at eyes that are having risk of going in for myopic maculopathy. And when you look at that angle and look at the contribution towards irreversible vision loss, then 6 diopters or more are the ones that have been found to have more of myopic maculopathy. Hence, we stick to the definition of more than or equal to worse than or equal to -6 diopters when it comes to clinical evaluation. So here goes the definition. Myopia is when the refractive error is less than or equal to 0.5 diopters. Low myopia is between less than or equal to 0.5 to more than -6. And high myopia is a condition in which the spherical equivalent is less than or equal to -6. Now, what is important here again is the sign that we use. So it's important to use the symbol of less than and not more than. I'm sorry about this mistake. This is something wrong on my part, but it's important to use the less than symbol because this less than actually is a mathematical notation. When you look at minus symbol, that it refers to worse than -6. So worse than -6, this is nothing but more myopic than -6. So in quantitative context, myopia should always be treated as a negative value, and the mathematical symbol used should be a less than symbol and not a more than symbol. And that's again important. Now let's look at why this is important. Now, why is this definition of 0.5, 0.75, all of this important is because this, again, an interesting paper published in British Journal, where they looked at the impact of this kind of definition, and they looked at 3 definitions of myopia, 0.5, 0.75, and 1. And when they compared it with a cohort of 1,800 odd people, what they found was between this M1 is -1, when they looked at M-1 as myopia, there were only 28% who were myopes. When they looked at -0.75 in the population, it jumped to 36, and -0.5 diopters, the prevalence of myopia actually jumped to 47%. Now, this is how important. There's almost a doubling of the prevalence statistic based on just the definition alone, and that's why the definition plays a very important role. Now let's go on to some descriptive definitions. Now I know that I told you that myopia has to be put into multiple buckets for us to understand because it's a complex disorder. We looked at qualitative measurements, we looked at quantitative, now we looked at certain descriptive definitions. Now the descriptive definitions are based on the structural aspect of myopic eyes, and this was a beautiful classification that is done, meta-analysis for pathological myopia study group. This meta-PM classification defined pathological myopia as an excessive axial elongation associated with myopia that can lead to structural changes in the posterior segment, and that can also lead to loss of best corrected visual acuity. Now they talk about it in terms of 3 aspects. So they classified as myopic maculopathy, posterior staphyloma, and high myopia associated optic neuropathy. Of course, the definition of optic neuropathy in this case is a loss of the neuroretinal rim and enlargement of the optic cup occurring in highly myopic eyes with disc or papillary changes at a normal IOP. So it's important to note the normal IOP there. Now, when we look at myopic maculopathy, which is the first part of the classification, again, we look at 2 aspects of the disease. One is a definition that is to look at the population-based statistic, and the other is the clinical definition. Now, there is a popular population-based screening protocol which defines presumed macular myopathy as one where the direct ophthalmoscopy shows a refractive error of worse than -5, or patchy atrophy, or sometimes even more than -10. Now, this is based on refractive error and not on the structural change. So you can understand this is more of a screening tool which can be utilized in the population to screen communities to pick out the risk of myopic maculopathy. However, this is not something that is more specific. Rather, it's a sensitive diagnosis. Whereas when you look at specific diagnosis, then it comes to this, that a vision threat, this is based on the IMI, a vision threatening condition where usually high myopia comprises of diffuse patchy macular atrophy with or without lacquer cracks, CNVM, and fugue spot. Now, so this is a sensitive definition, and this is a specific definition. When we go a little further into the classification of the meta-PM, we look at they're putting it under 4 categories. Category 1, and this goes in a flow. Category 1 is tessellation, just basic tessellated fundus. The second is diffuse chorioretinal atrophy, which is the figure B that you see. Third is the patchy chorioretinal atrophy, where you can see these patches of chorioretinal atrophy developing. And the fourth is macular atrophy, where you have macular atrophic changes. Now, again, there are some plus lesions which they talk about, which is the myopic CNV, which includes fugue spots and the lacquer cracks. Now, all of these are a kind of flow that happens, and in due course of time as the myopia increases. Now, it's important to understand that all of this need not happen with a -10 alone. Even a -4 or -5 can develop these changes, provided the age of onset is early. So what is more important in this is not the refractive error or the axial length per se. What is important is what age these kids started out with these pathological changes. So the second aspect of it was the posterior staphyloma, and this was the proposed nomenclature. You look at it that the normal eye shape is like this. A regular axial myope would probably have a uniform posterior elongation, whereas a secondary curvature is noted in posterior staphylomas with a small radius of curvature. And this is what is called as a posterior staphyloma, and this is a 3D MRI image. Professor Ono Matsui did a lot of work on this, and this is most of her work that we see. Moving on to the OCT. Nowadays, we have the OCT to help us classify this much better way. And you look at the beautiful posterior staphyloma that has been documented on an enhanced OCT. And you can see the classification that is on face as well as on the OCT. On face, when you look at it, these are the 5 classifications: wide macular, narrow at the macular area, at the peripapillary area, nasal to the optic disc, and inferior to the optic disc. Of course, there are other presentations as well that have been documented. So when I'm talking about OCT, there are newer kind of classifications that are coming, and one of that is called the myopic traction maculopathy. So what are the types that we are looking at? One is the myopic foveoschisis, and this is because of the traction that's happening from the vitreoretinal interface, that you see this kind of a skytic cavities that develop at the macula. The second that we look at is the myopic macular holes. Some of them can be without schisis, and some of them can be with a schisis component as well. And the third is the ILM detachments that are also seen. So these are the kind of findings or classifications that we see in myopic tractional maculopathy. Then we look at dome-shaped maculopathy. This is another thing that has been found recently with the OCT findings. And you can see there are 2 types in that. That is the vertical dome, wherein you see a vertical displacement of the retinal layers. And the second is the horizontal, where you see this kind of a horizontal stretching that's happening with the macula. So that covers the types of descriptive quantification of myopia. Now, what exactly is progression of myopia? Remember, we are going to treat only progression of axial myopia, and we are not here to treat myopia. So when we are looking at progression of axial myopia, what I follow in my clinic and what's probably universally followed also is a change of more than minus 0.5 diopters, a change of more than 0.5 diopters on cycloplegic refraction with an associated axial length increase in the preceding year. So if it's a young child, probably 0.2 mm per year would be considered physiological. Anything more than that is probably considered progression. And for older kids, it's less 0.1 mm per year. So this is what probably I would consider as progression. And nowadays we have these normative charts and emmetropic growth curves where we can actually assess and compare the child's growth with what is normative and physiological for that child's age as well. Now let's look at a small peek into the concept of premyopia. Premyopia is a refractive state of an eye that is between plus 0.5 diopters and minus 0.5 diopters in a child, where a combination of baseline refraction, age, maybe parental myopia, and certain other quantifiable risk factors that can probably lead to a future development of myopia to merit some preventative actions that we can take in the early stage. So this is something what we would call definition based on age. At age 6 plus 0.75, 7 to 8 plus 0.5, 9 to 10 plus 0.25, and 11 maybe 0 or emetropia. So this brings us to the end of it. So the question would be, why do we need to know definitions? It's important to know them because to begin myopia management, we need to know where the starting line is. And that's why this talk was put up by Dr. Jithani. Thank you so much for the opportunity, and we'll take some questions.
Thank you, Dr. Shruti. That was a very informative and well-structured talk. So the classification of myopia and its progression is not just a theoretical concept. It directly impacts how we anticipate risk, monitor, counsel, and manage our patients in our day-to-day practice. So most of the classifications use only refractive error, that is the SER for classification. But when we try to handle progression, we always talk about the axial length. So what's your take on that? Whether axial length is more important, or, and many cases we've seen that the refractive error remains the same, but the axial length has progressed. So what's your take on this?
So whatever we see, the ultimate goal of myopia management is to prevent myopia or structural changes to the retina and to prevent myopic maculopathy or such. So when we look at it from that point of view and that context, I always feel the axial length progression measurement is much more important. One, because it's more accurate than spherical error measurement. Like optical biometers have a spherical error correction of within 0.01 mm. So that's really good, 0.1 to 0.04 mm. So that's a little more accurate way of seeing things rather than looking at spherical equivalent. So I would probably look at axial length progression as a marker for my myopic strategies. And I think going forward, a combination of both would work. Of course, not all places have axial length measurement. A combination of both would work. But if I had something that I would really lean on to, especially when I have a difficult decision to make, it would always be axial length, and maybe others could opine as well.
Yeah, so just to add to it, that when we're looking at it, yes, true. We look at axial length, but we may have to look at the whole picture as well. So at the retinoscopy as well. And if you feel the axial length has grown, but you have not found a change in the refraction, call him back early. So we call them earlier. Normally you do a follow-up of 6 months, but here you have a doubt. So may not be always looking at the axial length alone. We decide, okay, it's grown, let's just start. If the child is comfortable with the glasses, it's not changed. Sometimes this much of error can come in the machine itself. A retinoscopy may not be as there. Somebody has done a fast retinoscopy, so we are not sure actually number has changed, but we have not done. So whenever there's a doubt, directly deciding on one, because only one of the factors has changed, might as well call them again, and then we can review. So call them earlier so that we really can document both. And I would believe that we should be able to differentiate an increase in power as well as an increase in the axial length.
Thank you, ma'am. There is also one more question from the audience. What should we consider as a gold standard for objective gold standard, that is objective refraction, retinoscopies or autorefractors?
I think a cycloplegic refraction is a must. Get a cycloplegic agent and you can calculate. Now, sometimes it's not easy to get a very good pediatric optometrist. That's true. So if you have an access, then that's the best, because manual refraction is always better than anything. But then if you don't have an access, then an autoref will also do. But remember, it should be a dilated refraction. A cycloplegic, the first time should always be a cycloplegic refraction.
And if we are falling back on autorefractors, we need to calibrate the machine regularly to make sure that it's working well, because retinoscopy is gold standard. Like ma'am said, it may not be practical in many times. So then we fall back on autorefractors on a maybe regular basis also.
I think once you do the cycloplegia, it becomes much easier because, at least it becomes more objective because the accommodation is under your control. Your accommodation is relaxed. So more or less the autoref will also give good reading. As Dr. Jyoti said, if you have an access to a good pediatric optometrist, or if you are doing your retinoscopies yourself, then, you should always cross-check.
And and in a child, we should always be very sure that sometimes the first reading does not always work. They're children, they don't cooperate. And then anytime you have a doubt, please call them back for a PMT. You do it again, you have a doubt and you don't want to give glasses, call them back again. So sometimes if you are in a dilemma, just don't go and do. And as rightly said, I think each of this module people will talk. We are not treating just a first patient with the first glass power. We are only treating a myopia which is progressing, and that I think everybody will keep on telling. And so we have to know. So we are giving the glasses for the first time, and if you have a doubt, call them again. There is no harm. Because in children, it's not always to get the answers immediately. Sometimes you have a busy clinic, you're not sure, you're confused, you're not sure whether the readings also right because it's not matching, then call them again. Call them when you are pretty lighter and do. But first time, once you decide and label a patient as a myopia, you should be sure that the glass that you've given is the right one.
And I think sometimes accumulative effect is also still there. So the kind of cycloplegic agent you are using, that also is very important because we need to nullify the effect of accumulation also to get the correct reading. Like ma'am said, we can repeat our reading and we can match with the auto refraction after cycloplegic effect is there.
Any further comments from the panelists?
I think something about tonus allowances in cycloplegia. I think when I've even atropinized some kids to make sure that, because sometimes the axial measurements and the spherical equivalent are like totally different. They'll be like this, -2, and the axial will be 22 or 22.5. And then even after cyclopentolate, and then I've actually put them on atropine and brought them back and then double checked. And so like we need to be really convinced that there is axial myopia, because before we start on any management, we need to understand we're putting the child and the parent through a lot of time, effort, and thing into this myopia intervention. So unless we are sure and we are really like convinced about the whole definition and progression of myopia, I think we can take our time in doing it slowly.
I think more than the absolute value of axial length, it is the change in the axial length which we should take into consideration.
Yeah.
And I think regarding cycloplegia, there's always going to be a controversy. Some people are comfortable with giving cyclopentolate. Some people say no, that causes. I mean, I'm using it for last 20 years, and I didn't have one complication till date. But that doesn't mean that it doesn't happen. So whatever is you are comfortable with, people want to give homide, they are fine. So it all depends on what some people want to give atropine under 2 to 3 years of age. So whatever you have been doing and you are able to get a good refraction, please go ahead and do that. So nothing is better than the other. Just be sure that the child is completely good amount of cycloplegia before you decide to give the glasses.
The endpoint of cycloplegia is very important, whether you take in terms of the accumulative reflex or the amount of pupillar dilatation, but that has to be ensured.
I think it's the cooperation of the child also matters a lot, because now we are getting so many myopias post ROP treatment. ROP treatments are becoming more and more better. And we are having myopia in as small child as an 8-month, 9-month-old babies who are coming to us with -4, -5, something like that. In those kids, maybe TD, putting a cyclopentolate homide in the OPD and then doing an AR really becomes a tough. That is when I think I also go with Dr. Shruti, that I also give sometimes atropine and tell them to come back with it. So it's not just about the tonus, but many times now we are having high myopes in very young infants. I think that's where we are being more into higher cycloplegics actually.
I think just to add a piece of advice, which I guess most of them know, but people who are starting their practice early, when you give atropine, ensure that you tell the parents the side effects. I tell them that the child will have a raised little warm skin and a little bit of red rash, but if it increases, stop the medication and go show a pediatrician. That's important. Also, the amount that you put should be as much as a small rice grain, because parents don't understand. So try to just make them aware when you're giving atropine. And I think twice a day is best to be put for twice a day for 3 days is good. The best thing you can do is put in the morning before the child gets up and night after he sleeps. So it's very convenient for the parents. Otherwise, it tends to come out. So that's the easiest way so the parents can be comfortable in putting it.
Even the photophobia aspect, ma'am, I think many parents call up telling child is not opening eyes now. So that also has to be told to the parents.
And I prefer the day they come in, they don't put the atropine ointment, because then it becomes so sticky that you cannot do. So like these kind of small tips are important, especially when you're beginning your practice. You don't want to be, struggling with these things. Because the parent will land up with the side effect of atropine and will come and like literally tell you never made me aware, and that can create a chaos. So it's best to inform them in advance.
You can just tell them the simple precaution, which is blocking the punctum to prevent the systemic absorption as well. Sometimes it really works.
So shall we go ahead with the next speaker? Am I audible?
Yes, yes.
Yeah. So After this insightful discussion, we would like to go ahead with our next speaker. Our next speaker doesn't need any introduction. He is Dr. Jithani himself. He is a renowned pediatric ophthalmologist in Baroda. He is well-renowned. He is the first pediatric ophthalmologist in Gujarat. And I would like to invite Dr. Jithani to give his talk on the myopia documentation and the diagnostic.
Thanks, Anupama. So I would be basically talking about what we should be doing, what we should be documenting. And once the patient comes to you and you have labeled the patient as myope, when the patient comes to follow up, there is always a small list that you should be doing, and there is almost always a small list of investigations that you may think that you can do. So the key components of progression, as Dr. Jyoti rightly mentioned, that there will be repeated talk, repeated discussion, repeated point that is to be taken is that we are talking about myopia progression. We are trying to slow down the myopia progression. So the key components for progression, we have to understand that we have to record and talk about and then see in the follow-up is refraction, axial length, because it is the axial length keratometry and maybe now choroidal thickness, but majority or bulk of your refraction, the first thing would change based on the K reading and axial length, especially in kids. Now, this is a small chart which I got from review of myopia management journal. I think this was published last year in May or June maybe. So what it shows is that with each 2 diopters of increase in myopia, there's a very high risk of myopic maculopathy. And this is what Dr. Shruti was talking about when she was talking about whether -5 should be a high myope or -6, where WHO felt that it is basically the visual disability, and -6 or higher axial length is now considered as high myopes, because the chances of other disease profile or comorbidities with myopia also increase. Now, this is a small chart which we follow in our clinic, where we try to record the progression of certain key factors like keratometry, axial length, and now AL upon CR ratio, because that gives us a clue that this particular patient is progressing and this particular patient would progress further. And we also had a small discussion on axial length. The reason why axial length is very, very important is because at the end of the day, what we are talking about is to slow down the axial progression. Even if myopia progresses on the basis of corneal curvature or index myopia, we as pediatric ophthalmologists, we are not planning to treat them on atropine or with myopia control glasses or other therapies. There are different ways and means to treat them. But for school-going myopia, it is purely axial myopia, and it is purely axial elongation which would be responsible for the bulk of myopia progression. So myopia progression, we have to measure how much is the progression and what is the progression. So which are the investigations we have to do? Without this, you cannot really do a myopia control practice or myopia progression control practice. Obviously, on the left side of the chart is visual acuity, which we all would be doing. Always do cycloplegic refraction. We already had a discussion on that. And as Dr. Jyoti said, that if you are not really sure how much to prescribe, you can always call the patient for a post-mediatic test. Try to be as accurate as possible when you give the glasses for the first time. Remember, undercorrections or overcorrections may be responsible for progression. So that is on the must-do list on the left side of the chart, which obviously bulk of us do. So what do we do as must-do test for axial progression, or what do we do when we want to evaluate the child whether he will progress further or not? So that is obviously baseline keratometry. If you don't do a baseline keratometry, it would be very difficult for you to know whether it is secondary to curvature myopia, whether the keratometry has changed, or it is the axial length which has elongated. Axial length, obviously, we must do in bulk of our patients, in most of our patients. Fundus evaluation is mainly not to miss out on peripheral retinal degenerations, may not be really important for axial elongation, but very important, because the whole purpose of all all this reducing the progression is to reduce the comorbidity. Tachymetry is not really a must do. You can do that. It is very, very important to look for pupil size, do a binocular examination, check for near point of convergence and accommodation and accommodative lag. Now, how does it help? See, accommodative lag, obviously, whenever you are trying to look at an object, the amount of accommodation you need and the amount of accommodation you are doing, the difference between the two is accommodative lag. It is said that myopes normally have a positive accommodative lag, and there is a chance that these patients would progress further. They do not accommodate as much as is needed. Pupil size is important if you are planning to give atropine or to start low dose atropine, because once you give them atropine, it would be very difficult for you to know what was the pupil size in the beginning. So you need to have a baseline pupil size. Any myope, even otherwise, even if it is not a myope, you should do a binocular examination. But if you are planning to do, investigate the kid or planning to start some treatment, it will be a very good idea to do binocular examination to know whether this particular patient would get affected because of low dose atropine or because of glasses. We should not end up into something new which was not there already. Near point of convergence and near point of accommodations are very important if you are planning to subject the child on atropine. So these things are important as a baseline, at least if we are planning to start them on low concentration atropine and if they are progressive myopes. Open field autorefraction is mainly for peripheral refraction. It is now that we have a certain kind of glasses which are myopia control glasses, which are basically to reduce the peripheral hyperopic defocus and convert the peripheral hyperopia into peripheral myopia. So if we are planning to dispense these glasses, we may do or can do open field autorefraction, because even otherwise also, and I think Dr. Jyoti has done extensive work on peripheral refraction, and not all patients in her work also were having peripheral hyperopia, and the glasses would still help even if there is no evidence that there is huge peripheral hyperopia. But this, if it is available, you can do. We do peripheral refraction with one of a small equipment that we have created. But you can easily do it by telling the patient to fix eccentrically and do a retinoscopy refraction to find out whether that particular reading with relation to the central refraction is slightly hyperopic or not. Even if you get a small hyperopia of plus 0.75 or plus 0.5, that is also significant. So here you can see that we are trying to tell the patient to fix temporally, to fix nasally, eccentrically, basically, and trying to find out what is the refraction in that particular position. So this is not a mandatory investigation that we should be doing in all the patients. But if you are planning to prescribe certain kind of glasses which can help in myopia, this would be really helpful. Again, corneal topography, if you have a topographer, it is always good to do a baseline topography to know whether it is indeed the axial elongation or some curvatural issues which are creating or which are leading to progression of myopia. Another important assessment is tear film assessment, mainly because once you are planning to prescribe low concentration atropine, you are actually in for a very long time. So you are going to give drops probably with preservative for a long time. So you would be giving drops for at least 2 or 3 or maybe 4 years. And so a baseline tear film assessment can be done, and it is advisable to do it. Another test, which is vitamin D assessment, not very popular. I would say that vitamin D has been implicated. In fact, in some of the subjects, in most of the subjects, in fact, they found that myopes were associated with low vitamin D, but a direct association that it is indeed vitamin D which is causing myopic progression has not been found. Mainly, these particular children are probably not sitting outdoors, and that leads to a confounding thing that vitamin D level is also reduced and myopia progression is also occurring. And the main factor which is affecting is probably sitting more indoors and not sitting outdoors. So if vitamin D assessment, it can be done, not really mandatory from our perspective. Research based, yes, there are there are devices which are available. Dr. Shruti has her own patented device where you can measure the amount of hours that the patient is sitting outdoors. This is a device which can be attached to the glasses, cloud clip, which can tell you how many number of hours or how many number of how many minutes or hours patient has been outdoor and how much near work patient is doing. Now this can, you can calculate it over a period of a week or so, and you can calculate how much kid is sitting indoors versus outdoors, and you can based on that particular data you can ask for behavioral modifications and what kind of behavioral modifications can be given. Another thing which is now coming into, now everybody is trying to move towards choroidal thickness and the importance of choroidal thickness, especially in myopic progression. Most of us now believe that it is the choroid which thins out before the actual axial elongation, and it gives way to the retina to grow. And so it is the choroidal thickness may predict myopia progression even before the actual axial elongation. So choroidal thickness is still research based, with some of the better swept source machines giving more reliable findings. Myopia calculators, again, pretty research based. There are some generic calculators like BHVI calculators which are available, and they can be used to predict and to map out how the graphs, how the myopia is progressing in last few years, and you can predict how much it will progress. Right now, they are pretty much in infancy because the myopia is multifactorial, and right now they have very few variables. And so yes, this would also be something which would be very, very important in future. And of course, genetic analysis, maybe in future we may see that we have the gene pool which is linked to that this particular patient would be progressing and this particular patient may not progress depending on genetic analysis. Now, newer optical biometers are coming up like Myopia Master, OBM12, which can do a comprehensive parameter measurement. They are specifically designed for myopia, and they will do the auto refraction. They will do the axial length calculation. They will do the AL upon CR ratio. They will do the pupil size also. K1, K2, of course, most of the optical biometers do. And some of the optical biometers, like from Topcon, they will do a corneal topography, Placido-based topography. And most of them, almost all three of them, do have their own myopia calculators where they can calculate which patient may progress further and how much it may progress. Now, this is just an example of one of the softwares. Like you can see that these are the variables. You can choose and pick the variable, put the data, and this is from Branholden Vision Institute. I'm just trying to show how to. This is a free software. You can go on their website and put certain data, and you can find out how much that particular patient would progress in future. If you use a certain kind of myopia management option, what will be the effect? And if you don't use it, they will show you in the red how much would be the myopia which will progress in future. So a lot of things are there for future. As I said, AI predictors, TFM biomarkers. Dr. Shruti has a wonderful article which was published last year in AJO on TFM biomarkers, how these TFM biomarkers do affect myopia and myopia progression. And we will ask her more about it once I finish off the talk. Long-acting molecules to treat and delivery systems. Another 8 to 10 years, we may see calculators, predictive calculators based on genetics, OPD strips predicting progression, response, gene interaction with environment, and maybe all these things may come in future. Right now, these are all sound very, very futuristic. So thank you so much. Thanks, Anupama, for the wonderful introduction. Thank you.
Thank you so much, Dr. Jethani. It was a wonderful presentation. You explained it very nicely. You begin with the basic setup. Like I think most of us have a basic equipments available to measure the myopia progression. So any of the ophthalmologists, like even the general ophthalmologist, can evaluate and document this myopia progression. Though many of the things are coming up in the future, including genetics and other biomarkers, so which can be helpful for the future predictions. But right now, anyone can document it thoroughly with the routine equipments. So any inputs from the expert panelist?
I think one thing which I liked when he started the presentation, that we are talking about slowing down myopia progression. So many a times people have the impression, and that we have to also convey to our patients, parents, that it is not okay. It reduces, it's fine. It eliminates, it's fine. But our idea is to slow down. So many a times then we also feel, oh, the myopia is progressing. But remember, the idea is where it was going to go by -1, it has come to -0.25. So that is our achievement. So sometimes we cannot expect it to completely stop. So let's understand that all we are talking is, like, again, treating a myopia progression and slowing down is the management of treatment. So I think I wanted to just reiterate this important thing that he spoke, slowing down. And I think very good talk. You've covered everything. And as rightly said, Dr. Anupama, basically anybody can start it. You just have to have the basic. And if you are running a myopia clinic, then obviously all these things are going to add. It can help add to the research that we can do, because that's what we want answers eventually. What can work, what cannot work. But a basic setup with a good refraction, good axial length, and those basic things, if you are able, and a keratometry to rule out that it is purely axial and not a curvature, we can definitely run a myopia clinic.
One way of counseling is usually we say, I mean, we can promise effort and the best thing, but we cannot promise results. Results is entirely how the child adapts to it and how the concept behind how it works. So whenever we counsel our children towards any myopia intervention strategy, of course, we provide the evidence that this is 50% effective in slowing down, this is 60%. But ultimately, it all boils down to how the child is going to respond to it and the lifestyle modifications the parents are going to uptake. So we should never promise results to the parents, and that's important. But we should always promise intent and effort. I think that's important.
I think, Shruti, you can give a little bit on what your paper was, so it can just add more value to your.
So mine was a research, yes, ma'am. That was a research paper. Like we had a question whether, because when we were doing our myopia workups, we used to do a lot of dry eye. I mean, we used to do a lot of dry eye workup along with it. And what we found that most of our kids who had progression also had dry eye. A relative amount of dry eye. I wouldn't say it's like significant dry eye, but they always had lesser values compared to say a normal child or emmetropic child or even a myopic child who didn't progress. And it was this question that put us through that thing. And then we started looking at biomarkers, inflammatory biomarkers in the tears. And we put them into 3 groups, emmetropes, moderate myopes, and high myopes. And we looked at how each of these groups, the inflammatory cytokines were there in the tears. And we found significantly higher levels of inflammatory cytokines in high myopes versus moderate myopes versus emmetropes. And this was also dose dependent. I mean, this was also refractive error dependent. And also when we eliminated the entire concept of dry eye and thing, it was still there. So there is an inherent inflammation or something that's there in the ocular surface that's probably also contributing. It could be a contributing risk factor to myopia. So I think this is somewhere like when we're looking at the field of biomarkers, because we're looking at how do we predict who's going to progress, who's not going to progress, then these kind of biomarkers become very important, like even OCT biomarkers, tear biomarkers. I think Dr. Jyoti had done a vitamin D, vitamin A, I'm sorry.
No,
Madam had done vitamin. Yeah, you had a tear study as well. You were looking at dopamine levels in the tears. And that was also something very interesting. She found, so these are all interesting biomarkers we're trying to look to predict. Like these things can give a bedside table test to kind of predict what will move on to myopia. And I mean, there's a long road ahead, but very promising research.
And I think one more thing I'd like, I mean, in addition to all the investigations, what I also add in my clinic is a questionnaire from the patient to basically ask about the time they spend outside, how much they do reading, how much time they do family history, any treatment taken. So a lot of questions comes while they are getting dilated, you have it. And before the patient walks in your room, you already have things like, is he an avid reader or not? So all these things I know, because sometimes you have given them the treatment, child is still progressing, then where is it going wrong? And you realize that the child loves to read for 5-6 hours. So those all things you can really pick up. So questionnaire is something that I would say that you can add in, and it's quickly done. Your parent would write it, and then you don't have much time to spend on that. So by the time he comes to your clinic, you would have something ready about his lifestyle also, because again, we know myopia is a lifestyle disease, and eventually whatever we treat, we have to reinforce changing lifestyle. So it's always good to have that in your hand, and subsequently do it at every visit, not like in a short thing, but yearly. Because even if you advise them, when they come back later, they are doing the same thing. Whatever you tell the child doesn't really change much, but at least you can keep on reinforcing as your advice when they come for the next time.
I think one thing which I've observed is that though we do all these plethora of investigations, especially the peripheral refraction in each and every case we see, but over time I've observed that you cannot use peripheral refraction as a tool for starting your treatment, because many patients, these optical devices you do prescribe even if you don't get a significant peripheral hyperopic defocus. I think Dr. Jyoti has done a lot of work on peripheral refraction.
Yes. So the reason, I mean, yeah, I did it, and we realized that irrespective of whether the child is becoming a myope, means he's progressing, he could still have a myopic defocus, and it could be still. So my idea of doing a peripheral refraction is to really know that if I am going to give the option of defocus glasses to his parent, I have a particular reason to prove to him why I'm giving it. The other thing what we have to understand is when the child is wearing a myopic glass, the glass alone causes a hyperopic defocus. The child may not have a hyperopic defocus, but when he wears a myopic glass, that induces a hyperopic defocus. But to start with, because I leave the option to the parent, whether there is to choose glasses, whether it is choose the eye drops, but I have something to begin with. And in my study, I found that irrespective of whether the patient is progressing or not, it's not that most of them are hyperopic defocus. I have so many who are myopic defocus. So it really doesn't matter, but then it is easy to tell the child, because where one place the classes are expensive, if eye drops, you're not sure about the compliance. So that's another issue. And it's not that. Suppose you have a child progressing at 7 years, till how long you're going to give it? So if you're going to give the eye drops till next 7-8 years, that is going to amount to the cost. So it's not going to be very different. So basically, whatever you do, when there is a defocus, I can at least explain the parent, okay, this is it. Now you can choose, it's your call. But if it still progresses, I will have to add the other treatment option. So that would work. So that's the way to just go about, because sometimes we are not sure what to offer the parent. This becomes a way to just start the discussion and explain to them. I think Jitendra has made a very good tool, and I think that is very simplifies. Somebody wants to try, you can do. So in his thing is like, basically you can do at multiple degrees. But the idea is at the beyond 20, if you're able to say there is a defocus, yes or not, is good enough. You don't really need it like a research to see how it changes. Any degree on any side, nasal, temporal, and we do even vertically, if there's a defocus, that means it amounts to considering that this child could progress. Why not give him the glass option?
I think similarly, axial length by corneal curvature radius, it does help you in counseling the parents about the onset of myopia. But actually, how much effect it has on the progression of myopia, that is another factor which is not very well answered, because many studies, they have proven that it has a role in indicating the onset, but not the progression as such. So any comments on that?
So we did some work on that, and we found that if your AL upon CR ratio is on the higher side, like if you, so what you have to do is when you make a myopia sheet, what you can see is that all these patients whose axial AL upon CR ratio, normally for a myope, if you have a AL upon CR ratio more than 3, there's a high possibility that the kid would be myope. Now this is known, but if your AL upon CR ratio is even further high, like around 3.2 or 3.3, the chances are that his progression rate will be there. The kid would progress. So AL upon CR ratio by definition will not tell you about the progression, but only about the onset of myopia, as you said. But if it is like in our practice, we have seen if it is more than 3.2 or 3.3, there's a very good chance that that particular patient would progress, because AL upon CR ratio by definition, only if axial length is high, only then it will be higher.
Yes.
And normally these patients have a flatter corneas because the cornea tries to compensate in these patients. So axial length, once it is growing, or even if you go by premo pre-myopia softwares, they would also say that if your axial length is more than 23.6, there are chances that this particular patient would progress further.
I think all these studies which are based on these ocular biometric changes, especially there was an article in IGO in which they have studied the VCD and axial length ratio. So that is another thing. They have seen that in high myopes, this ratio gives you a very strong correlation. So
Actually, there are interesting studies that,
Yeah.
sorry, you were saying something.
I was just saying that all these parameters you can calculate on the basis of optical biometer, and then all these ratios are being studied basically to understand how much they contribute towards the progression. Yeah, Dr. Shruti?
Yeah. No, along that thought, actually, there are interesting studies that look at axial length being a very interesting predictor for progression even before myopia onset. So especially in pre-myopes, if you just follow them with axial length, the previous couple of years, you're going to see this kind of an increase. Even if it's within the emmetropic, you'll start seeing this increase that happens 1 year before the change in the SCR. So that's one very sensitive indicator. Now they say another very sensitive indicator is the lens thickness or the lens power. So that also, now they say there's a calculation for the Bennett's formula for calculating lens power. And they say that the lens power actually starts to change 2 years before. And it's even more sensitive indicator of myopia progression than axial length. So these are actually, axial length is a very sensitive indicator. And once we start following it up, then you can actually see these really good predictions that we can make as clinicians, and we don't have to rely on these calculators and so on. But even clinically, we'll be able to make up these really interesting observations and then help us in management of myopia.
And in
Actually,
addition to these indicators, you also have things like, as the family history, what
Yeah.
the child's interest, his hobbies. So all these add to it. So you know that this child is eventually going to progress, his sibling has or not. So many a time. So yes, one, definitely look at these biomarkers. But in addition, also, you can actually sense that this patient will go into it. So in those cases, then you have to depend on your expertise and say, okay, it would need treatment, and then you can think about it.
I think the reason why axial length becomes a sensitive indicator is that, when axial length is on a higher side, rest of the eyeball tries to compensate. And all these indicators, like as Dr. Reena said, the VCD, it is basically, if you, there's a very good article from PGI Chandigarh on how in myopes, it is only the posterior segment which keeps on elongating, and they're not really, there's not much of elongation in the anterior segment. Possibly, so once you calculate the axial length with VCD ratio, it is only the posterior part which is progressing. So obviously that is the one which is contributing to the axial length. So the VCD becomes more sensitive compared to axial length, mainly because the change is occurring at that level only. The cornea is trying to compensate, trying to become more flatter, and so AL upon CR ratio will keep on going higher and higher because cornea tries to remain flat and axial length is progressing. That is probably
Which
the
tells
reason.
us eventually that axial length is important. So I think,
Yes.
something that we should show, many times it's been discussed, why don't have an axial length machine? We should just start treatment without it. But I would want to reiterate that yes, axial length is something that you should do in addition to whatever you're doing in retinoscopy. We cannot ideally have a practice where we are not doing. See, if we are a pediatric ophthalmologist and we are doing cataract, and if we are going to get an axial length done to calculate the IOL, then why not to run? So to run a myopia clinic, it's mandatory that we should have it to get the axial length done at least once in a year, if not 6 months, if it's progressing. I think this is some important message it should be conveyed.
Completely second you. You
Yes.
are
My question is
absolutely.
that
I cannot
And
just
it again
put it
doesn't
very
matter
correctly.
what machine you have, it is a difference. So you
Yes,
don't have
it is the
anything.
same machine next time also.
Yes, just see the difference. So it is not about doing ultrasound, or just see if you got this axial length, he comes back to you, you have the same machine, see the difference. That's all it's
Completely.
calculating. So that's what we should give the message.
I think I would put one point here, ma'am. Many general ophthalmologists, they don't understand the importance of axial length in these myopes. And some patient who had underwent an IOL master for the axial length elongation, they had told the parents that they have done your cataract evaluation and not done the myopia evaluation. So I think that plays a real important role. Not many people really know the axial length importance when we are talking about myopia progression per se.
And many a times they say there's no need, you may not need to do an axial
True,
length. Whatever
true.
we are discussing shows that this is the main thing, and if it is this, that helps us decide it over and above his refraction, obviously.
True.
Very true.
But
I
one
think
thing
once
I
we
would,
will
yeah.
have the newer biometers, no, the printout from newer biometers will not talk about IUL power. It will be talking about lens power, the Bennett's formula. And then it would be much easier to convince that it is not for the cataract workup.
Cataract
Probably.
workup.
I mean,
True,
so
true,
that is
true.
why we are now having I just saw your post. You have got the myopia master. So congratulations for that.
Thank you.
But
Thank you.
I think more and more people would now move towards the specific products, and then it will
Correct.
be much easier to tell the patient that, this was done for myopia management.
Because the name suggests that. Otherwise, I was having the tough time convincing a parents that I'm checking axial length in a machine which is actually not labeled for myopia. So, and many other people told them later that I was doing a different investigation rather than myopia investigation.
One point I would like to add is that these calculators and these apps like Premo app we have and the VHPI calculators, a lot of general ophthalmologists are using these tools to treat the patients. But more than that, they are a tool which we use to communicate with the parents. And because the data which they use, it's like a 2 or 3 data which has been spread all over the childhood, and so overestimations are there when you talk about the younger children. So I think clinical workup should never be, secondary to a calculator. That should only be used to communicate with the patients and the parents and to prognosticate the results.
See, although I agree with you that, clinical, it is, as you said, it forms the core of the whole thing, that clinical workup is more important than anything else. But what happens is that, people nowadays read a lot on Google, and they want some sort of a chart and evidence. So it is only, as you rightly said, it is only for the counseling part and not really for your workup. See, you may take a picture of a cataract not to know whether there is a cataract or not. It is just to show the patient that he has a slit lamp image, to show that he has a cataract. You already know there's a cataract. You don't need to take a picture to know whether there's a cataract or not. Likewise, only for their counseling, all these progression charts do matter, because they immediately get convinced that, oh, this is really increasing. So that is how it helps us in convincing them that the progression is there. Otherwise, for them, it is only a tiny bit of progression in last 6 months. It is only 0.5 diopters in last 8 months. But when they see an overall picture that in last 4 years it has progressed from this power to this power, they do realize that something should be done for this.
Yeah, because now so in the modified version, they have added that 0.02 and 0.05% concentration also, and also the combination therapy. If you fall within the 75th percentile, then you give a high dose. If below that, you can give 0.01%. So they are actually modifying it to involve the treatment part also now.
No, but there are, Dr. there are a lot of new Optometra is there, and Zeiss has come up with its own calculator. The OBM 12 has a calculator. So all these, the calculators are really, even LVP has a free software on the website. All these calculators do give a very nice risk ratio. It is more like the GCC kind of thing. It is in red, blue, green, and yellow. So it does give a good a good tool, at least to tell the patient that something is going on. I mean, progression is definitely there.
And some of them have the emmetropic growth curves, and I think that also plays a very good role. Like you have these K-mark growth. There are different BHVI has come up with, and so you can actually plot where the child is in the emmetropic growth. And then studies prove that across different ethnicities, the emmetropic growth curves are very similar. Once they become myopic, then it's completely different. But the emmetropic growth curves are very similar across ethnicities, so they're quite reliable as well.
For the prediction of myopia.
Yes, it's for the prediction.
It's a wonderful discussion. So we will move on to the next topic if there is no more comments.
I think there are few questions on the chat side. I think you can take those, Dr. Ankita or Dr. Anupama.
Yeah. So there are a couple of questions. One is about, can we start both the therapy at the same time? So they are asking about the combination therapy. Anyone want to take that question? Glasses and drop.
I think to begin with, for the first time, I would not immediately start combination. I would try to give one of them. And as I said, the option I always leave to the parent. But if he has a hyperopic defocus, I'll show him that this is there and this would be the preferred option. But either way, the success is the same either you take. But because this is an obvious defocus, I would prefer the glass, and that's how I would give him. And he would choose. Again, giving both therapies at the same time is like an overkill. We don't know which works. If you are able to show a progression after having started a treatment, then only I will add it or we modify. So I think what Jitendra said is that there is anyway a combination therapy, another module. But to begin with, I would always start one therapy, not both.
Yeah,
Yes, lifestyle changes must. You should keep on telling them. Remember, because that's one thing that has to be added. I give the analogy of a diabetic who continues to have medications but doesn't stop his sugars, continues to eat extra, then it doesn't work. The same way, lifestyle modifications need to be put over and above whatever treatment option you give.
Yeah. Now with 0.05% atropine, you have another option available. Like initially, I was giving 0.01% twice a day because single time it doesn't work much in the Indian population. So once you start with 0.05%, if 0.01 is not giving you results, you can switch over to a higher concentration, 0.05. Or there's a separate group like Dr. Jyoti said. If there's a peripheral hyperopic defocus, then you can shift to the optical option as well. You can prescribe those glasses. But in spite of those two things, if the patient doesn't work with 0.05, then you have always you have an option of giving a combination therapy, but after proper documentation that there is a progression. And also seeing the compliance of the patient, if the patient is compliant with the drops or not.
There's another question by Dr. Siddharth Madan. He's asking any specific glasses brand which is cost effective for the needy patients, or the cheaper version is available in the market. So anyone want to take that question?
Zeiss actually has for lower values, your refractive error spherical equivalent should be less than 4 and cylinder less than 2, because they already have these made glasses. So those are the only ones in which you can give cheaper. They're half the cost. But anything more than
people are
that,
interested. Yeah, ma'am. What about your take about the glasses, other glasses available by the Chinese and Korean brand, like from the Lenskart and other brand? What is your take on that?
so frankly speaking, whenever I have given glasses, I have tried the Hoya Dims, I have tried Zeiss, Myocare, and Stellest, and I have the Baltimore, and I found that these are equally effective. Many times I've given them and they have come back with the Lenskart, and few of them I've not seen doing very well because I'm not able to understand the pattern. So unless I'm really sure, because I'm not really advised, so I'm not really able to comment. But whenever I've seen people who I have recommended and come with the Lenskart, I'm not too happy about. They have still progressed.
Also,
No, go ahead. Please go ahead.
No, I think it's the Ondays brand, and that's what they have. And I did look up on the literature. I was not satisfied. There was hardly any literature on that. I did look up the specific study and the star mark and everything. I mean, it just wasn't. It didn't look robust. And also the kind of defocus is more like a stuck-on kind of a thing. If you look at the lens itself, it doesn't seem like there's a plus addition really going on. But again, the design of the lens is something I really can't comment on. But like, I would have a similar experience to Dr. Jyoti, that I really didn't see kids who were accidentally on that coming back, and they did have progression. Maybe not all of them, but most of them had progression. And again, we really can't comment on it because we don't know if it's the lifestyle or what exactly is also playing a role in that. But the studies were not robust, and that I can comment.
The only thing is that if you send them for a glass and they go to Lenskart, the first thing Lenskart people tell them is that you directly go for these myopia. So many a times, even if the patient is not having a progression, you would have sent a normal glass, but they will go and those people convince, and those patients don't progress. So I'm not saying that. So many times they're not needed itself. So if you decide to not give a normal glass, please tell the parents that wherever you want to go, you can take. But if they offer you any myopia control, it's not needed because your child is not progressing. So if you actually spell it out, then it's very easy. Otherwise, they will go and get that myopia control. And if you want them to still, and you say you get everywhere, but I cannot guarantee because I have not had any studies to confirm that these work or not. So wherever I know these, take these brands from anywhere, but these I'm sure will work as much equally. So you can take a call.
Yeah, I
It
do
looks-
agree because there's a group of non-progressors as well. And if they're wearing those glasses, the parents are so convinced it's only after the glasses the child was not progressing.
True, true.
True. And second thing
That's
is they
the
can't differentiate between the glasses also. The normal glass and those glass look very similar. So many a times I had one such case where my optician said it is not defocus glass at all. And they kept on telling me, no, it is defocus. So it becomes really tough to convince them also if when they get it online glasses specifically made for myopia segments.
And I think they're very cheap.
Yes, yes,
yeah, they
very,
give it very cheap.
very
Very cheap,
cheap. True.
5,000 for 2 pairs.
And they fought with me that the one you are suggesting is more expensive and आपका कुछ है क्या उनके साथ जो पैसा बन रहा है. So this also we have there. So
Science.
1,000, ma'am. So
हमारा science है.
Yes, fine.
No,
Okay.
the
One
problem.
more question, ma'am. Yeah.
Yeah. No, go ahead, Anupama. Please go ahead. I think I
No,
would be
sir.
repeating the
Continue,
same
sir.
thing.
Continue.
No, I was going to say almost the same thing as Dr. Jyoti said. I mean, I have patients who have gone to Lenskart, made those glasses, and I tried to, as Dr. Shruti said, I tried to also see through those dots. What are those dots? There are mainly some kind of film is there, and the dots are very much there. Then the design is very much similar. But it is almost like what was that? You can tell that there is some issue. You can easily find out there is no hyperopic. They are not plus lenslets or plus lenses. So and they don't work. At least in my very small experience, I think I have 6 or 7 patients whom we then switched over to the branded ones. In at least in those 6, 7 patients, they did not work.
I mean, they're called as polka dotted glasses.
Mhm.
Reebok.
Okay.
Instead of Reebok, you can have Reebok.
Yes, yes.
So,
One more question for Jyoti ma'am. Ma'am, what is your design of questionnaire? Are you going to share it or like you can
PDF,
brief it?
yeah, I just read that, but I don't know how to share it. But just let me tell you, we consider the age, then we write about the child sleeping hours, how much hours he is studying, which screen is he using. So for the near activity and how many hours. So we divide it as less than 30, 30 to 60, more than 60 to 90 and more than 90. Then we also are about the near activity, what activity and how much time. Then outdoor time, how much does he do? Family history, if the parent has, how much, mother, father, sibling, or any other person, avid reader or not, any treatment option or not. I think most of this I have covered. So basically, we look at everything to do, what is, and any additional hobbies, any exams that he's giving. So those kind of things tell us how much the curriculum also tends to affect the patient, and any prior treatment option. So these are the multiple things that we include.
Thank you so much, ma'am. So shall we proceed with the next speaker?
Yeah.
Any questions? No. Ankita, please introduce the next speaker.
Dr. Deepti Joshi from Joshi Eye Institute. She's a pediatric ophthalmologist and believes strongly in holistic pediatric eye care. She has a special interest in CVI and is actively involved in teaching and academic programs for postgraduate students across the country. So she is going to be walking us through the impact guidelines of myopia. Over to you, Dr. Deepti.
Thank you, Dr. Ankita. Thank you, Dr. Anupama. And thank you, Jitendra sir, for this wonderful opportunity. So my topic is impact guidelines for myopia. So we all know I wouldn't be going through these introduction topics. We all know that by 2050, this is a known guideline that 1 in every 2 child is going to be myopic and they're going to rapidly progress. And now with the neonatal treatment becoming more better and better, the number of childhood infantile myopias are also becoming high and high, which definitely will going into a rapid progression over a period of time. So there are, as we all discussed till now, there are multiple bouquet of options which are available for treatment management of progression of myopia, but one size does not fit all, and we all know that very well. So many times the moment we talk about myopia progression, so the few questions which are asked us, whom do we start? the anti-progression technique maneuvers. And then if at all you decide this is the person whom I'm supposed to start, when do we start and which one to proceed, and how do I taper when I'm trying to stop them? So these are few questions which usually pops up in any ophthalmologist's mind. So with those questions in the mind, the 6 steps of the impact guidelines were proposed by Dr. Kaikunaya et al. And they were, as the name suggests, impact. I, which is identify the true axial myope. M is mapping the risk factors. P is to pick the exact progressive myope. That's the whom part. A is which myopic control strategy to be used. So that is the which part. C, how do you manage it later? Consult, counsel, monitor. And then the T is how to taper and stop the myopia control progression treatment. So this was basically charted out in 3 steps: a thorough literature review, finalizing all the 6 questions, which then were put against with experts for the feedback suggested revisions. And then it was presented to the guidelines to various ophthalmologists, and then the confirmation was done. So it's a well-validated questionnaire which actually works across various grades of myopias which are now progressing. So let us go into each part of it. So the first one is the I, and that is identifying the true axial myope. So basically you need to rule out pseudomyopes and myopia due to other causes. Most of the part of this study has already been discussed, and that was the reason I was silent all through while thinking that my topic has already been covered over a period of the past 1.5 hours. So I would just rush through most of the parts so that there won't be much repetition part of it. So we identify the true axial myope. So we do a cycloplegic refraction, the keratometry reading, the axial length, rule out pseudomyopia, which is very common, especially during the exam periods, Jan, Feb, March. We get so many children with those of pseudomyopes. So after all these have been ruled out and you come to a diagnose, the part that this is the true axial myope, that is when you proceed with the next step. And that is to find out the risk factors. So are the parents myope? Is it one parent? Is it both of them? So 20 to 35%, or maybe it goes up to 40 to 50% risk that this child will progress and will develop myopia in the future. Early age of myopia onset, especially as I stressed upon with those of the recent ones with more digital usage as well as the ROP treatments and the neonatal therapies. Less time outdoors and excessive near work could be either with respect to books, or nowadays it's more or less a digital media which is causing that of the more near works. Relative peripheral, some ocular factors like risk factors like relative peripheral hyperopia, high lag of accommodation, or esophoria for near. So these are few of the risk factors which needs to be confirmed in every patient before we think of starting the anti-progression techniques, because what therapy we start in them, which type of treatment we start in them maybe matters with respect to especially the last 3 parts, the ocular risk factors which are present in the child. So now once you are done with M part, the next comes pick. So pick the progressive myope. So what exactly is the definition of progressive myope? According to the impact guideline, it states that an axial length change of more than 0.1 millimeter per, or an increase in the myopic refraction of more than 0.5 or more per year. So this puts us in this gives us an exact definition that these 2 changes when you notice, that is when you call that patient as a progressive myope, and these are the children who need the anti-progression treatments. So there are some people who are nowadays progressing more than, we are seeing a 0.5 per maybe 6 months, and so these children who progress to more than 0.75 to 1 per year, and these children are known as rapid progressors. So this is the guideline to whom a progress whom should be guided as labeled as progression, and these are the children who should be further picked up for the management of myopia. So then there is a second set of children. Now this falls into the gray zone, that is the premyope, which has already been discussed, somewhere between plus 0.75 to minus 0.5, and Dr. Shruti has already touched upon these. So these kids have to be really observed a lot, and many people do start some treatment, the anti-progression therapies in these children also. But otherwise, you need to look out for the high risk, whatever we studied till now, the second part, the mapping of high risk has to be done very severely in these premyopic individuals. And if you feel that the progression or the change in axial length is happening very rapidly, environmental lifestyle modification or maybe an intervention can be planned based upon their progression, which has been happening in these premyopes. So once you diagnose these people as progressive, now we have to decide which therapy to be started. So we all know that there is optical part, there can be DIMS, there can be Hall, now there care lenses, dot lenses, the orthokeratology, the bifocal, the EDOF contact lenses, or a low dose atropine, which now has gone to 0.05% also. So at appropriate starting of the appropriate treatment strategy has two parts to be taken care of. The one is the ocular part, especially as already been stressed. If there is a peripheral hyperopic defocus, glasses would be the preferable optical technique, would be the preferable maneuver. Special care to be taken to check out for the accommodation as well as any presence of exotropia or any intermittent squints. In these situations, your glasses may worsen and accommodation lag by esophoria. So this has to be taken. Either again, the treatment aspect changes with respect to this. But then it's not just what we see clinically which decides that this would be the appropriate treatment strategy, but even the personal conditions like the parental compliance. As already discussed, the drops would go on with for a very long duration of the time, and a sudden cessation of the drops definitely can result in rebound myopia in children, and hence the parental compliance, their education, financial status. Many a times parents are not able to afford the glasses, but then the cumulative, if you think around the both the drops, the glasses come to the same level. But many poor people, at least in my OPD, they are not able to afford these high-end glasses in at a very single sitting. So maybe drops in those situations, at least we are able to stop some progression, and then the refractive error of the parents has to be considered. So all these things put together, so the ocular part of the child, the personal part of the child, the familial aspect of the child, the parental part of the child, all these things together put together will help us to decide, so this child needs this treatment. So there is no one treatment per child. It has to be customized, looking at the family as a whole, and that is when an ideal anti-progression therapy will be started to that child. So once you start the anti-progression therapy, the next comes consultation. Every 6 monthly, all the investigations which were mentioned by Dr. Jitendra Jetani sir, ideally it should be done every 6 monthly. If not possible, at least the axial length and all has to be repeated yearly. But the consultation has to happen 6 monthly to look out for the cycloplegic refraction, to look out for any progression. Initial part, when you start, it would be ideal to call them after 3 months, especially if you are starting a drops, to see if there is any side effects or the compliance has to be checked in those situations. The next comes the counseling part. You have to tell the parents a long-term therapy would be needed. No matter which anti-progression measure we check, the therapy level would still be a long-term. The side effects of discontinuation, and always we need to stress on the lifestyle modification paths. That's basically without which 100% none of our therapies are going to work. Myopia progression is not just us pediatric ophthalmologist job. It is the job of parents. It's the job of the child. It is the job of us. So it's a combined effect which is going to work over there. Has to be reiterated to parents every time we advise a therapy to them. Combination, despite 1 year, according to impact guidelines, despite 1 year of monotherapy, if your child is still progressing, that's when you go ahead with the combination therapy. So it could be a combining a drop with a glasses, combining a drop with orthokeratology. So different maneuvers can be combined, and that is the combination therapy part. And monitor the child to look out for any other side effects like the pupils, the accommodation, the new onset squints, all these things which can sometimes happens with atropine eye drops or the glasses which have not been made in a proper way. So a good treatment effect, no matter what you start, is a change in axial length of less than 0.1 millimeter per year, or a change in refraction of less than 0.5 diopter per year. So once all this is done, we come to the last part, that is the T. T is tapering and cessation. So it's according to the impact guidelines, it's at least for 2 years, or maybe you can continue up to 17 to 18 years of age of the patient till you consider a cessation. And whenever you consider a cessation, it always has to be tapered, especially when you're starting a drops, it needs to be tapered. And if at all you feel that once you tapering and it's again progressing, you may have to switch them back into continuous drops, and once again till maybe the stability has been achieved. So with till the stability has been achieved. So with this, these are my references. I would like to say that no matter what the impact guidelines say, every day with every step, our myopia management has been changing. The myopia protocol progression management has been changing. So these guidelines are just the gist of how you tackle the child. But no matter what, every time you see a child, I think there has to be some modifications, both with respect to your clinical as well as with respect to your management aspect. Customize the treatment. There is no one treatment or one anti-progression technique which is available for all child, that this will be first, this will be second. That's absolutely not possible. So with this, I would end my talk and I open it to the panelists.
Wonderful talk, ma'am. And I like that point that you specifically told that it's not only the parameters which we should look to decide the treatment, but also the personal and the other factors which we should look into. So, any comments from the panelists?
I think, no, it's a nice impact that you've left. And I hope that impact has also been on all the people who are watching the presentation. So I think it's a very good, there's an IGO, this is an IGO article that has come in. So you can
Yes.
just fill it and we'll be able to go through it. So it's available.
I think it states all the 6 steps very wonderfully. So
It's actually a very good article because I read it. So it's really summarized everything.
I think we've discussed so much, there's nothing more to discuss, looks like.
my article was discussed even before I started my talk. So we had finished the impact
It was
discussion
the final
already.
impact after having discussed.
Yeah.
It's a
It felt
take-home.
like a nice rounding off of the
Rounding
discussion.
up
like
of all the
everything is in a
discussion.
nutshell
That's
and-
what I said. And all the 1 hour I was thinking, Array, this topic is covered, this topic is, so I'm gonna
I'm telling you, this entire module, I mean, good, Jitendra, you're covering it. It's going to be a repetition. And unless you keep on talking the same and keep on reinforcing, it's difficult for people. So those who are practicing, it's easy for us. But for a lot of people who are starting afresh, this is important. So the more and more you talk again and again, then it finally gets, implemented.
Yeah.
So,
Actually, there are so many aspects to this, ma'am. The module 1 was entirely different when compared to this. So the discussions were very different. So I really like the idea of this modules.
yes.
The discussions are really happening in a very nice way.
I think every
It's like
time
a
you
very deep-
discuss, you
yeah,
find something new in myopia, which can be discussed further.
I think everybody of us is learning. It's not like all of us know. If there is so many things I heard through Shruti's talk, or something or the other is always new that we get to. Because we are in practice, we believe, oh, this is how it is. But some new ideas help us to modify our, I think. So everybody in whoever is practicing myopia is going to learn through this module.
Definitely, ma'am. Definitely.
And actually, it is the exchange of ideas which probably has made all this possible, because the whole idea that myopia can be treated over. I think it has been almost now 10 or 15 years that atropine came and glasses came, and we are having talks on whether red light can be used, and then newer advances on tear film biomarkers, genetics, a lot of exciting things. And the problem is, once you are in the practice, it becomes very difficult to imbibe what new is going on. Like, especially for us who are into private practice, it becomes very difficult to know what is going on. And because in institute, you have a lot of people to talk and a lot of exchange of ideas keep on moving. In private practice, what happens is that you're doing something and you feel that, as you said, that you feel that this is what should be done, and you keep on doing the same thing.
I think in the last 3 years in India, we have been very active and there's constant discussions happening, which is, making people change. When myopia, this drop came in 0.01, we had general ophthalmologists also prescribing it for uveitis. For anybody who had any reaction, 0.01 was being given. It was like amazing. I mean, good for the
This had
pharmaceutical
given for
company. They had a
astigmatism
huge
also.
sale, but it is ridiculous. So people thought, oh, this, they. So it was like a very sad thing. But now the awareness has come. Even general ophthalmologists are keen to know. So these modules are going to help them, because anybody and everybody should be practicing this eventually, because it is, as you said, and eventually going to be a major issue. So the more people understand, they start introducing it and using it, it always would help our general population.
Previously, I had seen many prescriptions with astigmatism also being prescribed.
Astigmatism.
But those are reducing now. So
Yeah.
I think it's good.
But that actually started with more of a with the optometrist. So recently we had, not recently, about 2 years ago, we had a meeting with the optometrist to talk. So a lot of them were advising defocus glasses. And it was very weird. They said, okay, but there is a myopic astigmatism, why not? So many a time we had to really explain that it is not to be given for anybody, and especially with the person coming first time, that also astigmatic correction. So it was really needed to make them understand. But now the awareness is quite a bit, people are doing. But on the other side, now everybody's making their defocus glasses. So that is what is happening, and they're trying to give. So every company who was initially not introducing defocus have now started making their own. So now that is another, difficult thing to a challenge for us to make the parents realize that.
Yeah, it's like over treatment now.
Yes.
Yeah, I think we should have one person talk about whom not to give. I think that's important as a take home, because it's just so prevalent nowadays to give. I think, like ma'am, as she said, it's astigmatism, ROP, myopia, and children who have any other syndromes or any other syndromic type of myopes, any positional myopia like lens related myopia, any cornea or curvature related myopia, and all of these really do not require low dose atropine or spectacle lenses. I think that's again something important we all need to.
That again comes to the same thing. Axial length needed. You're proving it's an axial myopia. So axial length measurement is a must in any myopia clinic.
So it's
Ma'am, I
basically
understand
that
one
when they
thing,
get the glasses with us, we can control it, ma'am. But when they go out and get the glasses, then it's not in our hands. So
So
many a
our
time.
idea is to create the awareness to this. A lot of people will see it and will pass on the information. So that way, these kind of modules and training programs would really help.
Now, one point which has come
One
is
question.
nowadays late onset myopes are also there. Like
Yes,
children
yes, yes.
above 14, 15 years of age, they are coming and first time they are being, identified as a myopia. So one of the point is that you continue till 17, 18 years of age. I think this is also something which is arbitrary because nowadays it's progressing even up to 20 years.
The problem with Indian scenario is about the competitive exams and all that, and that is very, very true. More than children, parents are very keen
Yes.
that they do, and this goes up to 18, 19, plus then they go into medical or anything. So basically in ours, it does not end like other, like the eye atom and all was till 12, but for us it's beyond. So even if a patient comes at 16, we cannot say, oh, it's gone. So it's therefore important, even then monitor them. And any evidence, that's why here it's important to then stress on how they can improve a little bit of lifestyle also, because then they're going to progress even after 18. So then we have to work it at the whole, but yes, you may need to give it longer also. So we have to, as she said, customize, look at each child, each patient, each children is a separate entity altogether, and they have to be treated separately. I think there's one question about whether a normal A scan or an immersion again. If you're not able to do an immersion in a child, don't push it. You can do normal A scan. We're looking at a difference in the A scan value over time, not on getting that. So the same technique which you use once and 6 months later, if you're finding a difference, then it's important. Don't worry about which machine and how you do it.
Ma'am, in any case, have you prescribed myopia control treatment where there was there's no documented progression, but the risk factors were high or something? Any comments on that?
No. So I have the advantage of being at an institute, and I have the privilege of having everything. So I'm always at a place where I can get access to. So it's never happened that I would not get. Yes, maybe you are finding a child who's progressing a lot, myopia, he's mentally challenged, not able to do. And there you are knowing it's going, and you have seen 2-3 episodes where it's gone from -2 to -3 to -4. And those are very, very rare cases where you can. But most of the time, we can get everything done. But again, I said, okay, even if I have an institute, there are people, if you are getting a refraction done, an axial length done, you have done a keratometry, ruled out other causes, this is enough for you to decide because the child is progressing and you're watching the actual myopia grow. So then it's important. And you're then looking at things like parental myopia, sibling myopia, his other lifestyle, what is he doing, all fitting into something, this would progress. So then you can follow.
Actually, I wanted to ask the panel this question, like as much as we all, I think in Indian ophthalmology, we talk a lot about progressive myopia before we start intervention. But it's important to note that the ATOM studies, the LAM studies, all of them were not on progressive myopes. They were just myopes. So they were diagnosed myopes who were started on all of these treatments. So like, what is your opinion on that? And I mean, I don't see any of these landmark RCTs on progressive myopes. And if they do call it, then they call it, I mean, only Indian studies have that. Like the Indian studies always start atropine or whatever it is after noting down progression. So I just want to know your opinion on that.
So India is actually a low cohort, means low myopic cohort. We don't expect our myopes to really progress, but wherever these studies are done, there's about 90% risk of progression. So when they believe that that child has myopia, they are sure this is going to progress because their parents, their sibling, all would have had myopia. So in those kinds, so the cohort we are looking at is a totally different cohort. So there it's, unless proven otherwise, will progress. So that's the reason why they would have seen and immediately started.
I think there are two set of patients here now. One is a child who's a myope, but he's not progressing. And second is a child who's losing his hyperopic reserve very quickly. So for the second category, I think you can still start the intervention because they come under pre-myopes. But a child who's not progressing, I would not want to start the treatment.
But with multiple risk factors, as ma'am said, if there are multiple risk factors where parental myopia is there, the child started off with a very high power. So in those cases where the child is not outdoors, So in those cases where there is a high risk factor, do you still believe that we can start myopia treatment measures? Is what I was wondering.
But you can keep them on a close follow-up. See, if you call them back after 3 or 4 months, I don't think their myopia is going to progress like more than 5.5 diopter or 0.75 diopters. All in all, if you have a extremely super duper progressor, in 3 months the kid is not going to progress more than 0.5 diopter. See, the whole crux of the matter is that if you know that this patient is going to progress, and if he is progressing, see, the treatment is as at the start we all discussed, and Dr. Jyoti and Dr. Reena, Dr. Jyoti, everybody said that you are treating the progression. Now, in the absence of progression and only in the risk of progression, but there is no documented evidence of progression, I personally, in my own practice, do not start treatment. Maybe I am into private practice, so I don't start treatment, because what am I treating? I am treating progression. There is no progression, documented progression. Of course, there will be some anecdotal evidences which may not be actually cycloplegic refractions. Sometimes, patient comes to us as pediatric ophthalmologists. We see a lot of patients who are wearing -3, and we actually see, and it comes to -2. So when we do cycloplegic refraction, we see a lot of pseudo myopia also, and so it becomes very difficult. So then, what are you treating? Patient actually was -3 when he walked into your clinic. You are giving -2, and you are telling the patient that you have -2. Your power has gone down, but it may go up, and so it becomes very funny actually, because patient immediately says that he was doing some jadi booty kind of thing, and that probably has helped. And now you are into another situation where you are telling him that you are giving glasses, and in another year the kid will have -3, which he is currently wearing. And that also is the reason why a lot of places treatment works. There is no progression, but he was already given overcorrection. So there is no progression. How there will be a progression? He was already overcorrected.
So that's what, sir. Actually, I've seen many prescriptions where in the first go they've been given glasses. So I was just wondering whether that's really ethical in doing that.
Not only ethical, see,
I just wanted
scientifically,
this discussion here, sir.
no, but scientifically, what are you treating?
Correct.
See, maybe in few patients, as Dr. Jyoti said, maybe in few patients you may be ready to make an exception that, patient has a strong family history, and a sibling has already progressed, and parents have. Maybe in some patients you may make an exception, but otherwise, why would you make an exception? You don't have a progression chart. You don't know whether he is progressing or not. And I would say a good 30% may not progress. It's not that all the patients progress. And so the difficult thing is, when you want to stop the treatment, you don't know whether your treatment was working, or he is in those small percentage of cases who was even otherwise not going to progress. So your treatment is completely like, this is like drawing an analogy on ocular hypertensives. We are treating, but what are we treating? There is no optic nerve, damage. So what are we treating actually?
I think we should not underestimate lifestyle modifications as well, because they
Yeah,
really work.
right.
They really work.
So actually, I had a patient, parents high myope, child had high myopia, and he was an avid reader, and he kept progressing. He's on combination therapy. His brother is a e-metrope. Last 3 years, I'm watching him, and his hyperopia is also not reduced. So I was sure that this patient, so I even thought, should we try to consider him for glasses like this to prevent like a premyopia, but his hyperopia is not reduced. So then how do we explain? Everything is fitting, but the child was a avid reader, and he reads about 5-6 books in one book in a day, literally like that. And this person is outdoors, and literally. So I'm not saying that this is the only reason, but he is not progressing. Both parents are. He's a last 3 from 5 to 8 years. I'm seeing he's not progressed. He's not even developed myopia. So it's like so different. So we need to really decide. Otherwise, I would have started him on something like, say, any pre-myopic treatment, and then I would have got thinking, oh, this really worked, but it really didn't work. So we also have to be vigilant about what we do.
Totally.
Some comments are there in the comment section.
Yes. There's a question about, apart from the increased outdoor activity and the lesser screen time, what are the other lifestyle modification to that we consider?
I think good posture is also mandatory, and continuous breaks are required. Lighting is very important. like as close to this natural sunlight. You should try to maintain that. And also a sleep pattern, I would say, a regular sleep pattern of 7 to 8 hours of sleep is also very essential.
And especially if somebody is into reading or anything, the 20-20-20 rule, it's easy to give them some numbers so they tend to follow. And I always tell them, try to put it into your little practice so that eventually, as you start getting more and more studies, this becomes your routine. And if you are not having, literally put an alarm after 20 minutes so you get used to looking outside. When you're memorizing or something, just glance outside the window. Because the fact is that a lot of teenagers prefers to have the room dark. They pull down the curtains. They don't want light in it. And that's very routine. Everybody says, no, we want it little, it's too bright, too bright. So they avoid this kind of a thing. So trying to reinforce that becomes important.
Extending
One
on
more
that
question
thought,
we are.
yeah, just one more point on that. Like, many of them think they have good lighting in the room and they pull down all these curtains, but in fact they have very bad lighting because the lighting is either coming from the back or from the side. So always a desk lamp, and we found that out in a questionnaire survey thing, that desk lamps are somehow they have much better control of myopia progression, at least through the survey part that we saw in consecutive longitudinal follow-up. So desk lamps to add, and also just sitting near a window also helps. It gives as much sunlight exposure as does sitting under a shady area, like a tree, under a tree or something. So whenever given the chance to just at least sit in the balcony or in the or near a window, or all these kind of things would actually be really good substitutes to being directly under sunlight.
Yeah, so that way it works like indirect sunlight works there. And also by default, you have the 20-20-20 rule, because once you look outside, you're by default looking far. So that works the same way. So two things you do by just sitting close to a window.
Yeah, I keep telling my patients, if you don't have time, you can read under sunlight. You can just go to your terrace and read there. So at least you are being exposed to that.
I think many are reading on Kindle nowadays rather than reading the book. So nobody goes out and reads. It's because of
So you
the
can take your
contrast.
iPad and go outside.
So just a quick question, how much near is really near? Like 25 centimeters, 30 centimeters, or 35 centimeters? What everybody prefers? Like, what is near work? That is what is a very frequent question which will be asked by the parents. How near is near?
So
I say 1 feet. Yeah.
Yeah.
No,
Yeah.
go ahead.
Yeah.
I usually say
Yeah,
just
but-
1 arm distance. I just say put your arm out. At the end of the arm is where you need to keep your material, whatever it is. So they have a really good distance when they're reading. At least they attempt to keep it clearly far. And they try to have some threshold where they could keep their clothes. That's what I suggest.
I say 1 arm distance of 14 inches, but the best thing I tell them is the book should touch the table and your back should touch the chair. So that's the way. So then children have a habit, they keep it, but then they start going close. The book is at the distance. So now I keep telling them the child's back should touch the chair, the book should be on the table. Then it can be any. So then they understand that this has to be maintained, and hopefully they'll not go close.
Yeah, I agree with Dr.
Many-
Shri. That's what I have to keep telling you. Just hold your elbow and then just open it. That is the distance which children can correlate with. So that much is a near.
Many a time we get the question about the diet. So what is your answer to the parents when they ask question about the diet? What should be our diet to control the myopia progression?
I talk about visual diet. I say your child needs to be on good visual diet.
I think there is something of a probiotic which has come up for dry eyes. I was just looking at it and I thought that now that Dr. Shruti has published on inflammatory biomarkers for myopia, soon we will get some ocubiome for myopia also. So open for everybody. I mean, you also must have been approached by the companies about probiotics for dry eye, which basically is about the low grade inflammation that happens in dry eye. I don't know whether that is happening for myopia or not, but to the experts and speakers.
I firmly
But they
believe
talk
there
about
is
these
some.
gummies and they say, okay, let's give. It may just work.
Yeah.
So, but I don't.
Gummies are vitamin D gummies.
Vitamin D gummies.
Vitamin D.
I don't believe in giving any of
Gummies.
these kind of.
A, D. No, but I firmly believe there is some inflammation or something going on. Like sometimes, like Dr. Jyoti was saying, there's one kid who's completely has all the risk factors and is emmetropic, and there's this other kid who does all the right things and progresses. So we need to look at more things in it, and I somehow feel inflammation could be an important player there, maybe.
Okay,
Any
great.
other?
So I think, yeah, Dr. Anupam.
Yeah, one more question we get, like what kind of light should be better? So this LED or the natural warm light, because now we have multiple light source available. So we have any answer to this question? Like what kind of light we should prefer in home?
LED.
LED is the answer. Okay.
There was one controversial study that LED light increases myopia.
Yeah.
There was one paper. But there was a lot of confounding, like myopia is such a multifactorial disease, it's like people who wear yellow t-shirts have more accidents on the road, but that yellow t-shirt guy was actually holding an iPad and reading while on the road. So you really don't know. So it's like, it's just
Very
so
difficult to
multifactorial.
comment on a single factor,
Factor,
especially
yeah.
light, it's very difficult. How many hours of near work with indoor lighting? It is extremely difficult to comment the lux, luminance, what is going. It's extremely, as Dr. Shruti said, multiple confounding variables. It is very difficult to control those variables.
Just good illumination of the visual area.
Not
I
be
think
any ocular strain.
Yeah, that should be enough.
I think as you sit closer to the window and let the natural light come in, so that can be there. Obviously, after evening, then you need to change, but try to illuminate what you're watching would really help.
So practically the near distance, that like the reading distance, it matters. Sunlight, it matters to control the myopia, and the outdoor activity. So that is what we can tell our parents. Yeah. So should we, any other question?
Okay.
So should we conclude our session?
Yes.
Yeah. So after such a wonderful discussion, I would like to say thanks to everybody, our speakers, Dr. Shruti, Dr. Jithani, and Dr. Dipti. I would like to thank our experts, Dr. Jyoti ma'am and Dr. Reena. I would like to thank Ankita for such a wonderful discussion. So we will wind up this discussion today and waiting for the next module. Thank you so much, Dr. Jethani, for starting this session. And thank you, AIOS and Dr. Namrata, for giving us this opportunity.
Just a quick comment. The third module will be on premyopia. It is on Monday at 2:30. And there is in the comment section, they have sent a link for the questions, the MCQs and the quiz, the questions about this particular module. So people who have registered should attempt those questions for the certification, and it will be coming to them also. So the link is already there in the chat box. Thank you so much. Thank you, Dr. Jyoti. Dr. Reena, thank you for wonderful comments. Dr. Shruti, Dr. Deepti, wonderful talks, amazing work, and Dr. Anupama and Dr. Ankita for keeping us all together into the discussion. Thank you so much, and have a nice day.
Yes, thank you.
Thank you. Thank you. Bye-bye.
Thank you so much.
Bye.